not everybody who's obese has sleep apnea. Not everyone who has sleep apnea is obese, but it is linearly correlated. What does that mean? Well, it means as your sleep apnea gets worse, you're more likely to be overweight. You tend to be heavier the worse your sleep apnea gets. But this is the most telling thing, though. The weight starts first. There are the sleep heart study, the multiple studies out there that show most people's weight starts to go up before the sleep apnea starts.
Hi, everyone. This is Dr. Lee here with Dr. Ben for the Vital Discourse podcast. Welcome. Today we're going to be talking about sleep apnea and obesity. Sleep apnea we've talked about before, and as we know, it affects a lot of people. I think Dr. Ben and I both get a lot of people that come into our office, and they're wondering how obesity affects sleep apnea. Does it cause sleep apnea? Does it make it worse? So first, Dr. Ben, tell us what sleep apnea is, and then give us an idea of how obesity affects it.
Yeah, so the new definition over the last 15 years or so is that sleep apnea is a progressive weakening of the structures of the throat with an asterisk. There's a lot of things that affect that. In general, what structures are we talking about? We're talking about your palate and tongue. Usually there's a nasal obstruction involved in that because this is a physics problem. And so if you think of it in terms of what we call technically a Starling resistor, for all those folks out there that are engineers or have a bent towards physics, but in general you can think of it like a paper straw that you stick in Sprite. Everybody knows that. So if you stick a paper straw into your Sprite, you suck on it, it works great. 15 minutes later, the straw has changed over time. That's what we mean when we say progressive weakening. It's changed over time, and you go to suck on it, and everybody's been frustrated when it collapses on you. So it's important to remember those two things. Your throat is like that paper straw, and over time, it's changing.
Ben, that's one of the best ways to discuss and explain what happens that I've quite frankly ever heard, because I
always say that to my patients.
Yeah, I've never heard that in a talk from anyone or anything like that. You know, they'll throw out Starling resistor and that kind of thing. Who the heck knows what that is? Most doctors don't know what that is. But the way you described it, how the straw, how it gets wet over time and it becomes more pliable, and then all of a sudden when you're sucking in, it's collapsing on you. That's really great. Tell us, how do I know when the person next to me it might have sleep apnea? What's the technical definition, so to speak, of what's happening? How many times does it have to happen for me to get worried? That type of thing.
So quite often, 40% of America snores, as you know, and so that's the first alarm bell that you're changing. So I always tell my patients, when I walk in, I'm not 18 years old because I have gray beard and some wrinkles. And you don't have to be a doctor to recognize those changes in the face. How do you recognize the gray hair of the throat? The gray hair of the throat is the snoring, so it's the sound. So the first thing that starts happening when that straw in your throat, right, starts to get weaker is that it's no longer able to stay open when you take a full breath of air, especially depending on how open your nose is. So snoring is the first sign. Not everybody who snores has sleep apnea. And so how do you know when it's starting to change? Snoring is quite loud, and obstruction is quiet. You start to take pauses when you're breathing. So quite often family members will come in and say, well, he was snoring, but lately he's been pausing and then taking gasps. That's a good indication that it's starting to get worse and starting to decompensate and might be time for a sleep study. When you have a sleep study, when you go to a professional, either a sleep doctor, and there are many types of those, or an ENT who's focused on sleep, they're going to do a sleep study on you where they actually look at you over 1 or 2 or 3 nights, and they put some sensors on you that can tell how low your oxygen goes and how long these pauses are. And so what we look at is the data from those sleep studies. And if you pause and drop your oxygen in a defined way more than 5 times in an hour, that's sleep apnea. More than 30 times in an hour is severe. And so a qualified professional will take that information and talk to you about what category you're in. Treatment is sort of laid out based on risk, and the risk is stratified in mild, moderate, and severe. That risk, of course, Lee, is what we're all talking about. What happens to you if you do nothing about it? And so...
So for our audience, basically what sleep apnea is a cessation of breathing. You stop breathing despite trying to breathe. So you're trying to breathe, but there's an obstruction and the air stops flowing. So it could stop flowing completely, or it could stop flowing partially, and you can get a drop in your oxygen saturation because of it. So let's move to obesity, because I can't tell you how many times I see a patient in the office and they say they went to their primary care physician, and their primary care physician told them, look, just lose weight, you'll be fine. Okay? Many times they don't even do a sleep study. They just say, I'll just lose weight, you'll be fine. Other times they do the sleep study and they say, just lose weight, you'll be fine. Tell us 2 things. Tell us first why they're wrong, okay, in terms of that the obesity is the defining issue in their sleep apnea. And number 2, tell us why it's not so easy for those people to lose weight.
Yeah, so you're getting right to the heart of it, and that's great, because I can tell you that the patient population is pretty varied, and it's not exact. So not everybody who's obese has sleep apnea. Not everyone who has sleep apnea is obese, but it is linearly correlated. What does that mean? Well, it means as your sleep apnea gets worse, you're more likely to be overweight. But it's not a lot. So at its highest amount in severe sleep apnea, it's about 60% of people are overweight. But down in the mild and moderate range, it's only about 30 and then 40%. It does get higher. You tend to be heavier the worse your sleep apnea gets. But this is the most telling thing, though, and this is what everyone needs to realize, is that the weight starts first. There are the sleep heart study, the multiple studies out there that show most people's weight starts to go up before the sleep apnea starts. And to your point, what happens once you start to get heavy? Well, you just say to yourself, well, why don't I just try and lose weight? Once you have sleep apnea, a couple of major things start to happen. Remember, sleep apnea is about interrupting your sleep, most specifically the slow wave sleep, the REM sleep, the sleep that makes us feel good in the morning. In order to have a good night's sleep, you got to go into slow wave sleep and have multiple episodes of REM during the night. That's when your body relaxes the most, and that's when your throat closes the most.
Okay, so people have heard about REM. Tell us what REM is.
That's the rapid eye movement. That's the part of sleep where your brain goes through certain processes that make you feel rested in the morning. Your brain has to go through this in order to wake up feeling refreshed.
Just so people know, the reason that our muscles all relax during REM sleep is our dream level of sleep, right?
Yeah.
So we don't want to act out our dreams, right? You don't want to be dreaming of going off the cliff, and next thing you know, you're leaving your house and then jumping off a cliff.
I've done a lot of facial trauma in my career on people that have had REM disorder, where they don't go into a relaxed state. They act out their dreams, and they've done terrible things. One guy about 5 years ago, he was a high diver in college, and his wife saw him get up, walk to the end of the bed, and face plant. He dove off the end of the bed and smashed his face. And so it is an emergency. I mean, people do things that hurt themselves and others when they're doing this. So you have to relax, and your body needs to go through that. But when you do, sleep apneics close their throat, and that fractionates their sleep. It breaks it up. So what happens when you break up your sleep? Well, one of the first things that happens is that your growth hormone burst that happens between midnight and 4 a.m. goes away. Almost immediately, actually. And that's responsible for most of the growth hormone during your day. So, well, and the other thing that causes a cascade of events hormonally inside your body that changes your basal metabolic rate. So we know that growth hormone, everybody knows growth hormone. Yeah, you're short if you don't have it. It does so much more than that. It's the master hormone of your body. It basically tells your body how to utilize energy. Every single one of our 37 trillion cells in a male, 35 in a female, has a receptor for it. So we know also that it tells the mitochondria inside those cells to utilize fat instead of sugar. So it fundamentally changes how you use energy. And then there's a couple of other hormones you should probably know. That's leptin and ghrelin. Ghrelin starts to become very high. It's basically telling your body, because your body's feeling like it's in a fight or flight mode all the time when you wake up after not having a good night's sleep, it wants to get you eating to get your energy up. And so you start snacking a little more, maybe grab an energy drink, and so you have high ghrelin. The other one, leptin, ghrelin and leptin, you guys have probably heard of all of this. It gets thrown around the internet all the time. You become leptin insensitive. So these two hormones are kind of complicated, the way they interact, but hormonally inside, it makes it so that you can't lose weight. And then you get into a vicious cycle. Because if I have sleep apnea and it's untreated and I go out and walk a mile, even if I'm probably too tired to do that, but if I can go out and work out, I walk a mile and you walk a mile, I'll lose nothing, you'll lose a pound. So the person that has sleep apnea is now no longer able to lose weight as well, and their weight goes up, and of course that makes sleep apnea worse. So that's why you start to get more people being obese the higher you go, mild, moderate, and severe in sleep apnea.
And so the takeaway for this is that sleep apnea lowers your metabolic rate, right? It lowers your metabolism. You can't work off your fat. And so when your internist, when your primary care physician says, just lose weight, it's not so easy, right? And the vicious cycle that Ben was talking about, it's real. As your sleep apnea gets worse, you gain more weight, you can't get it off. And the more weight you gain, the worse your sleep apnea becomes. Now, why does weight gain lead to more sleep apnea or worse sleep apnea? Why elevated weight, increased weight, has negative effects on sleep apnea. So they're both anatomy effects, structural effects, mechanical effects, hormonal effects, like Ben was speaking about. So this is the thing that I tell patients that really astonishes them is that when you gain weight, you actually deposit fat in your tongue, in the muscles around your neck. The actual muscles themselves get fat deposits. And when you get fat deposits in those muscles, the muscles don't work as efficiently, right? So it puts extra bulk, extra weight on those muscles. That narrows the airway. The tongue gets more fat. That narrows the airway. And that's a big issue, because when we're talking about the diameter of the airway, we're talking about, at times, depending on what we're dealing with, a game of centimeters, if not millimeters, in terms of the collapse of the airway.
But it's not just the size, though, right? I mean, because we know that the static size of it is not so important. That's why a CT scan can't really predict sleep apnea or an MRI. But it's the critical closing pressure. Back to that physics thing that we were all talking about, the Starling resistor. One of the things that affects the collapsible too, and by the way, just for geeks, it's Ernst Starling we're talking about, right? So he actually first did his work in vessels, and air's a fluid, so it's how fluid moves through a collapsible tube. This is a collapsible tube, and the thing that weight does is it changes the critical closing pressure of that airway. So it may not be the overall size per se. It may be the weight that's causing it to close more easily during a full breath of air.
Or the negative pressure that occurs, and that goes on to a whole different
correct
physics lesson. Another
Right.
thing people don't realize, and I'm sure you see this when, for example, if you're doing surgery on someone that is not intubated. So intubated is when you put a tube down someone's throat and the anesthesiologist puts you on the machine, so the machine is breathing for you. But many times we'll do procedures where patients are under intravenous sedation, kind of like when you're having a colonoscopy, that type of thing. And in those cases, we see that people that are obese or people that carry more weight, they tend to not have such great oxygen saturations. And the
Yeah, they
reason
drop
for that
immediately.
is,
Yeah.
right? The reason for that is because what does that belly weight do? That belly weight keeps the lungs from completely expanding.
Yeah, you remember your diaphragm. That's right. If you tell them what why that is, why a big belly hampers breathing.
Right. So when we're breathing, our oxygen saturation is directly related to how well the oxygen passes through our lung tissue into our bloodstream. Okay, and that is a function of how much the lungs expand. The last bit of lung expansion is actually the greatest indicator as to what our oxygen saturation is going to be. So if you have a big belly, keeping the diaphragm up and not letting the diaphragm pull down and pull those lungs open, the small little openings or small little sacs called the alveoli, they don't get enough air. And when they don't get enough air, our oxygen saturation drops. And if our oxygen saturation drops, then the same amount of obstruction in obstructive sleep apnea will cause an even lower oxygen saturation. And when we have a lower oxygen saturation, our heart has to work harder. When our heart has to work harder, like any muscle, the muscle starts thickening, and the muscle thickens inward, not outward. So now our heart chamber gets smaller, and eventually the heart fails. So these are the types of things that people don't realize that occur. Another thing, tell me a little bit about neuromuscular control and how fat impairs neuromuscular control of the muscles that are responsible for keeping our airway open, Ben.
Yeah, so again, it all goes down to deposition of fat. You know, we've all seen how we change from 18 to 40. You go on pictures and you can see people's neck getting bigger. We think of it as typical aging. It's actually not. It's more linked to our diet. So when you deposit fat around these muscles that are key to keeping your airway open, not only do they become more narrow and they're easier to collapse with a high stream of air, but the muscle control, they become more floppy. So it's the things that are causing sleep apnea, like progressive weakening, are being aided by the deposition of fat in that muscle. That muscle is no longer as responsive as it was before. So in every way, fat deposition anywhere in the body, in the belly, particularly in the belly and around the neck, worsens the things that we know by physics cause and progress sleep apnea.
Now, here's a good one. Everyone on the internet, you see someone hawking something saying that inflammation is evil and we have something that's going to get rid of your inflammation. Tell me how, or tell us how fat promotes inflammation.
Well, I don't know what you're getting at.
So adipose tissue fat is actually pro-inflammatory.
Yeah, no, absolutely. Yeah.
Right? So it increases...
So you're talking about whole body.
Right. So IL-6, that type of thing, hormone changes, the leptin and ghrelin you were talking about before,
Right.
All of this increases inflammation, insulin resistance, fatty infiltration of the upper airway. All of this is, these are the metabolic and inflammatory and hormonal effects that you were talking about before. But inflammation in the airway further decreases the size of the airway, further increases the airway's propensity to be floppy and close down, right? We all know that inflammation is going to swell things. So last thing we want is swelling in the airway when we're dealing with someone with sleep apnea. So just the effects of weight, excess weight on sleep apnea, although Dr. Ben correctly said that fat or obesity in and of itself doesn't necessarily cause sleep apnea, it certainly makes it a heck of a lot worse. And as a sleep surgeon, it makes it a heck of a lot more difficult to treat, right?
Yeah.
So that brings us to the ultimate question. What do we do about this, Wade? What can we do about it?
So, in my practice, I do a couple of things about weight. One is I make sure to address it to the couple in a way that doesn't put the onus on that person. I make sure to tell them that it's very hard to lose weight now that you're up there. I just one thing that it's important to let everybody know is that you don't want to sort of blame that individual per se. Yes, I mean, the weight's been going up, and so it started the sleep apnea, but now you're in a vicious cycle. Getting that weight down has to be a multi-pronged approach, because we've got to do something about the sleep apnea in order to make it so that they can lose weight. Otherwise, what winds up happening quite often is that there becomes a tension in that relationship now. Hey, if this guy would just, stop getting up and eating at night, we wouldn't be having this problem. So I try to make sure to let them know that when you're in this, you're in the fight of your life here, and you need a lot of help to get back to a place metabolically where you can lose weight. And that brings up a great thing, though, Lee. What's going on with these GLP-1s? How do they help? How do they hurt? And what part do they play? What role do they play once you're getting the sleep apnea under control? Helping people breathe better, helping open their airways with one of the methods we're going to talk about soon. How do you manage weight loss in that setting?
Well, and that brings up a great question, because as we've talked about before, GLP-1s, they don't only decrease your fat, right? They decrease your muscle. Right? And as we just said, muscle tone is a very important part of keeping your airway open. So if you're decreasing your muscle, you're decreasing your muscle tone, and you could actually be making your sleep apnea worse. Now, what do we see? We both see in our practice the male that comes in on testosterone, taking a fair amount of testosterone, working out like crazy, neck, the size of a small state, and wondering why they have sleep apnea.
Wondering why it's getting worse instead of better.
Right, worse instead of better. And then you have the person that comes in that says, yeah, I have sleep apnea, and my primary doctor checked my testosterone level. My testosterone level was low, and the doctor said that my sleep apnea is because my testosterone level is low. Tell us why that's wrong.
This is a common sequence that we see. So the first thing you start to know, so the sequence is you start to put on a little bit of weight, maybe in your 30s. You start to snore and have sleep apnea, but you're not really focused on that. It's just snoring after all, right? Uncle Jack's snoring. So you go to your doctor. They don't really say much to you about it. Maybe they ask for a sleep study. You're not there yet. And you find Cenegenics, or I don't know if I should say Cenegenics actually. But you find some T center, and you go to the T center, and you're looking for a reason why you're feeling tired. And so they check your T, it's low. We've already said that all of your hormones start to go off when you have sleep apnea. That's one of them. And they replace the T. The problem is when in isolation you replace T, usually they do it super physiologic, and they get you from anywhere from 200 or 300 where you were up to 900 or 1100, and all of a sudden you're starting to get hypertrophy of these muscles all through your body, but also in your neck. The muscles that are getting weak with sleep apnea, they start to hypertrophy, and that narrows it even more. You also get water gain and weight gain from that. And that, again, in the neck, that does not help. That hurts. So you start taking T, you feel immediately better, and within a week or two, you start to drag again and feel worse. It's because your sleep apnea is getting worse.
So should those people just go off their testosterone?
Not necessarily. We have a weight loss center here that comprehensively analyzes your basal metabolic rate, your VO2 max, looks at all of your labs, and combines the use of GLP-1. Remember, GLP-1s are peptides. They're based on peptides. They're slightly changed for patent sakes, but they're basically peptides. With the rise of Zepbound, We know that a lot of people are being put on it specifically to decrease weight and sleep apnea. Again, by itself, it can be detrimental. You can lose weight, but you can also lose the rigidity of those muscles. And so really, we try to keep on the lowest dose of GLP-1 to start getting you to lose weight. My team is working diligently trying to make you breathe better at night, fixing your nose, maybe a CPAP mask, maybe a stimulator, something to keep it open. And then we test all of your hormones and see where you just might need a little tweaking. Remember, getting you back to physiologic normalcy is the goal, not one thing inside your internal picture. It's all of them together. So comprehensive management is the key here.
And so I think if we're gonna give a vital point of the day, right? I think the vital point of the day is that just because you are not overweight does not mean you don't have sleep apnea. Okay, you have the same risk of having sleep apnea if you're normal weight versus if you're overweight. However, if you are overweight, and particularly if you are obese, it's certainly, if you have sleep apnea, making your sleep apnea worse.
By the way, Lee, why don't you tell everybody, what does obesity mean? What is obesity? What's the definition of it so everyone knows what we're talking about?
Well, the technical definition in terms of body percentage and percentage body weight and that type of thing, I'm not enough of an expert on that to tell you that. But I think that if you look at elevation in weight, once that elevation in weight starts affecting our metabolic processes, our physical processes, and in particular our sleep, whether you classify it as obesity or not, it's an issue.
Okay, good point.
Okay, so our vital point of the day is, if you are not overweight, it doesn't mean you don't have sleep apnea. And if you are overweight, that weight, if you have sleep apnea, is making it worse. That's what you have to take away from this.
Yeah, that and the fact that because of that, the corollary is that when you try to treat sleep apnea, you have to treat it comprehensively. You can't just take a GLP-1 or try and change your diet. You have to try to fix the sleep apnea as you are losing the weight. And to do that, a lot of people need professionals to help them.
And seek out a sleep surgeon that knows what they're doing, that knows sleep apnea, that treats sleep apnea, because we don't operate on everyone. Just because you come to a sleep surgeon, it doesn't mean that we're gonna recommend a surgery. We know it best because we know the anatomy.
Good point.
So thank you so much for watching us today and listening to us. For those who don't have video, we're really happy that we're able to bring you this information. And just make sure you go out there, and if you know of anyone that might have sleep apnea, or your spouse or your bed partner might have sleep apnea, make sure they get to someone and get it looked into and treated.
Yeah, look, I would add that thanks so much for listening to us. I think that weight and sleep apnea is on everybody's mind. As a nation, we're getting heavier, and sleep apnea is so prevalent, with 40% of America snoring and 60% of us overweight. The Venn diagram is obvious. And so I would say that to all those couples out there that are struggling either with a partner that's having sleep apnea and sleep difficulties, or sleep apnea yourself and keeping the whole house up when you're snoring, there is help out there, and it's not just weight. It's a two-way street. It's a little complicated, and getting professional help can start putting you on the right course towards total treatment.